Hello, everyone. Happy Friday. You're only going to hear one R today because Prof. Rez is very busy on clinical service. But we're thrilled to have you today. It's so funny how things work out in life. I accidentally let in somebody I hadn't met into the behind the scenes action. His name is Zach Owens. He's a resident at Emory joining us today. And we got to know each other a little bit and he offered to present a case. So Zach, please unmute. Tell us a little bit about yourself and welcome.
Yeah. Hey everybody, nice to be here on Virtual Morning Report. I've been a long time follower of the CP Solvers. So glad to finally be here and be able to present a case with you guys. Like Robbie said, I'm a second-year internal medicine resident at Emory, planning on either hospital medicine or possibly a fellowship in the future. But really enjoy these VMRs, really enjoy teaching and clinical reasoning. So really like what you guys do here, and I'm happy to present a case.
Zach, it's a real treat. Thank you. I'm so glad I accidentally hit that button and so glad that you're here to present and to get to know you this way. I was telling Zach behind the scenes that we've been so lucky. We're getting closer and closer to 1,000 VMRs. And I realized we haven't made something explicit about presenting in a long time. I think we do actively recruit people to present in real time, almost always, though sometimes we have some prepared cases. And the value of presenting is massive for your own skill set. And I think you shouldn't lose sight of that, representing that skill set that you have. So in the email that you all received to log on to this meeting are instructions about how to add this to your CV. And its weight in your CV is ever increasing. There's more and more recognition of these kinds of activities as being equally impactful as traditional academic activities. So please put them on there. And the truth is you are all part of the ever increasing impact of CP Solvers. And so if you do it on your CV, others do it on their CVs, that carries more and more weight. And we hope someday it'll carry as much weight as it should, because presenting a complex case in a public forum in real time is not a small task. So Zach, I hope you get as much juice out of this case as possible, including all the learning from it today, growing your skills, and also on your CV. All right, you ready to rock and roll?
Yeah, let's get started. So just chief complaint, we have a 27-year-old previously healthy male coming in with 2 days of progressive neck pain, headache, and fever.
That's incredibly alarming. And so since Reza isn't here, the other R will be all of you. So I will share my thoughts and give you time to collect and share yours, but please put them in the chat and I'll try to highlight as many of them as I can. Zach, I think what you just did there is something that is very subtle, but very important, which is you told us exactly what's going on, but your voice changed and your emphasis level changed when you said previously healthy. And I think immediately your mind, an advanced clinical reasoning mind, is dividing this case into the background and the foreground. And by telling us very quickly and very concisely and precisely that you're saying the background here is minimal to none. Of course, they may be things in terms of exposure or family history that is relevant background, but the most important, powerful background usually is the patient's past medical history. And the fact that that is relatively empty is really important, though it comes with a caveat that the patient may have a sinister occult disease that may not have risen to the surface and may be rising to the surface now. However, I think when you see the constellation of things that we're seeing now, you have to worry. The reason you have to worry is fever, as we've learned over and over again, we got to translate that into inflammation. And most of the time, inflammation is infection, and infection follows a typical base rate of disease. The vast majority of infections are non-specific viral infections that affect folks, followed by 6 common bacterial infections. And those are in the skin and soft tissue, in the urinary tract, in the respiratory tract, in the biliary tract, in the gut causing diarrhea, or bacteremia of unknown source. So immediately, no matter what words Zach uses subsequent to the word fevers, we have to think about those. And then use the subsequent words to help us funnel our workup, not to skip over what's common, because no matter what the patient says, common things are common. So the real question in this case is, how much do the symptoms symptoms of headache and neck pain deviate us from the base rate? And the answer is enough to worry, but not enough to avoid the workup. What this means is no matter what, we will probably need testing for common viral infections and all those 6 common causes of bacterial infections. But what else do we need to look into? And I think that's the key question. Headache is an incredibly non-specific symptom that often flares as part of a systemic illness causing a headache. It happens with mononucleosis infections, it happens with COVID, it happens with influenza, and does not have any localizing value, as Vale masterfully talked about yesterday, in a case that had nothing to do with fever and nothing to do with what we're talking about today, but similar enough to reflect on. Neck pain is the same. Neck pain, just like lower back pain, is often a chronic issue that flares up when patients get ill. However, there are 2 reasons that what I just said doesn't apply. One, there's headache and neck pain occurring synchronously, which breaks the usual pattern, and this patient does not have a background history of headaches or background history of neck pain. So this immediately mandates the concern for infections within this space. The most notorious and morbid would be considering the possibility of meningitis. I'll leave it at that. Base rate never, ever, ever walks away from the case. But even though headache and neck pain independently are fairly non-specific, the fact that this patient has no background headache, no background neck pain, and has neck and head pain coming in synchronously makes us immediately worry about the possibility of a meningeal process. I'm going to scan the chat now to see, wow, y'all, I don't know why I just said what I said. This chat is basically saying something very, very similar. Vale, Amanda, and David highlighting these points. Okay, all right. Zach, why don't you tell us more?
Yeah, so 2 weeks before admission, the patient was actually traveling to Belize and had kind of an extended vacation there. While there, he spent a lot of time outdoors, had a lot of mosquito bites, didn't take any malaria prophylaxis or get any pre-trip vaccinations, but didn't have any symptoms while he was there. So he was doing relatively fine until about 2 days prior to admission, when he had a relatively abrupt onset, left-sided and posterior neck pain, as well as a severe 10 out of 10 occipital headache that progressively worsened over those 2 days. And the 2 nights before admission, he was having some subjective fevers, drenching night sweats, and shaking chills. Also having some other kind of systemic symptoms like some mild nausea. But from what he said, he didn't have any conjunctival injection, no jaundice, no retroorbital pain, arthralgias or myalgias, or new rashes. Sorry if I talked too fast. I'll try and be mindful and slow down for those scribing.
Awesome. Thank you so much. Yeah, you know, I think what has just happened is incredibly powerful. I'll just reflect on the big picture view, which is when we're thinking about infections, we're usually saying this is either a community-associated viral infection, like COVID or influenza or RSV, or this is a commensal bacteria, usually a bacteria that lives on your skin that invades your body, like you having Staph aureus in your nares and it going to your lungs, or you having strep on your skin that goes and causes cellulitis, or you having E. coli in your GI tract that causes a diarrhea or a UTI. But I think as soon as you realize that this patient's community is different than what you were anticipating it to be, all of a sudden that initial hypothesis of community-associated infections changes dramatically. So it reminds us of the key principle of solving infection, which is you need to know the 4 W's. You need to know who the patient is, and Zach's already told us this is a 27-year-old previously healthy person. You need to know when, what is the time course, and the time course here is 2 days. You need to know what, which is the dimensions of the clinical syndrome that we're continuing to build. They're characterized by fever, headache, and neck pain, but we'll know more later with incorporating labs and imaging. And then the final W is where. So who, the patient, what, the syndrome, when, the time course, and where. Where they are dramatically influences the infections that you consider. And I'd love for the chat to help me out and see if anybody can use the CDC website. Literally just Google CDC in Belize and see what are the common infections in that community. It's a fantastic website that can be very, very informative. So in general now, the problem representation had changed to saying that this is a fever in a returning traveler. And you have to be careful because, well, let me just say it this way. Pay attention to the order. This is not a returning traveler with a fever. This is fever in a returning traveler. The order matters. By starting with fever, you remain anchored in the reality that the problem you're trying to solve is fever and the modifier is a returning traveler. It does not mean that the fever has to be from the fact that this person has traveled. If you code this in your head as a returning traveler with a fever, you're over prioritizing the travel. That's why we say this is a fever in a returning traveler. And the single most important variable that helps you understand what risks this patient, what infections this patient is at risk at by that modifier is the incubation period. Why? If the incubation period is less than 3 weeks, it is virtually impossible for it to be tuberculosis or brucellosis or schistosomiasis with some exceptions, or leishmaniasis. They are infections for whom the incubation period is so long that you cannot connect them to the travel simply because the infection occurred too soon. In opposition to that are infections with short incubation periods. If the infection is supposed to present quickly and it doesn't, then it's not in play. So here we learned that the patient traveled to Belize 2 weeks ago. So it has to be an infection, if it's related, that is within the 2-week incubation period. The most common causes of infections in a fever in a returning traveler with a short incubation period are dengue, Salmonella typhi, and malaria. There are, of course, a wide variety of other viral, bacterial, and parasitic infections like Babesia, but the fungal infections are not at play when a patient has an incubation period of less than 2 weeks. So now we know this is the 4 W's: who, what, when, where. Where makes it fever in a returning traveler. The returning traveler incubation period is key, and here it's less than 3 weeks. So our focus should be on the base rate, which would tell us dengue, which would tell us salmonella or malaria. But based on the patient's exposure in Belize, we'll have to think about some other ones too. And I see Rebecca sharing a great resource from the BMJ. Thank you, Rebecca. It's nice to see you here. And all right, cool. Yeah, let's get some more data.
Yeah, some great discussion here. In terms of past medical history, he does not have any known past medical history. The only thing he mentioned when we brought this up was about 4 to 6 weeks ago, he did have like a very mildly symptomatic COVID-19 infection. Didn't require treatment or anything like that. In terms of medications, he's just been using as needed ibuprofen for his neck pain and fever, but no other medications and no other allergies. In terms of family history, no pertinent family history. From a social history standpoint, we talked about his travel history. Aside from that, he smokes about 1 cigar daily, drinks alcohol on the weekends, and uses marijuana daily. Otherwise, no recent travel, is self-employed, and no pertinent like recent sexual history or anything like that. And I'm happy to move on to the physical exam as well, or if you think there's anything that you'd like to discuss in there, we can pause here.
No, I love that you emphasize the sexual history. I think that the rate of sexually transmitted infections is higher in patients who return from travel. And I think it's important not to forget that, because that opens up the bucket of both common sexually transmitted infections like syphilis and HIV, but also other conditions that we don't think of as sexually transmitted, but more transmitted with exchange of saliva, like the mononucleosis infections. I remember we had one VMR where we were like in the world of esoteria thinking of like what could this be, and the patient turned out to have acute mono. So yeah, I think the sexual history is important in these cases. And it's so important that honestly, even if there is no report of any sexual activity, the base rate would tell you to probably test them in these patients. All right, tell us more, please.
Yeah, so we'll go ahead and move on to his exam and vitals. His fever or his temperature was 101.7 Fahrenheit. Heart rate was 96. Respiratory rate was 16. And then his blood pressure was 121/65. And his pulse ox was normal. In general, he was well appearing, lying comfortably in bed, no acute distress. For his HEENT exam, he did not have any scleral icterus. His conjunctiva were clear without pallor, and his mucous membranes were moist. On his neck exam specifically, he did have bilateral neck tenderness in the paraspinal area with a little bit of cervical lymphadenopathy that was non-tender. Cardiac exam was normal. Pulmonary exam was normal. And abdominal exam was normal with no palpable organomegaly. Let's see, extremities and skin. He had several like red macular patches across, some on the inside of his forearms, one on the side of his neck, and one on his back that were kind of ovoid in shape, flat, blanchable, non-painful, non-paritic. And otherwise, his neurologic exam was normal. He had negative like Kernig and Brudzinski signs, didn't have any meningismus or focal neurologic deficits. Yeah, and I'll leave it there.
Yeah, no, I love it, Zach. I love the close attention to the skin exam, because the truth is, in most patients who don't travel, who come in with fever and neck pain, unless the patient has purpura from Neisseria meningitidis, I'm probably not going to notice a rash as subtle as that. But I think in this situation, looking very closely is really important, because I think it skews the differential quite a bit. So y'all, what do you think about the rash? I'll pause and collect your thoughts on the rash in the chat. In the meantime, I'll ask Zach. I was noticing that you were emphasizing the conjunctiva. Maybe I misread that, but you deliberately mentioned the conjunctiva in this case. What were you thinking about?
Yeah, I just think in people who are coming in with like a febrile jaundice is like a key clinical finding that changes your differential diagnosis. So that's something whenever I admit somebody with fever, it's just something that I make sure to pay attention to. But particularly in somebody who's coming back as a fever with a returning traveler in a region where malaria is potentially endemic, it could be a sign of like hemolysis leading to indirect hyperbilirubinemia. I'm not entirely sure if yellow fever is endemic to Belize, but that can also cause jaundice, and is something you should think about if someone's returning from the appropriate setting. Yeah.
I love that. The eyes tell it all. And as
Yeah.
Rebecca's saying, lepto can show up too.
Yeah.
And conjunctival subfusion, absolutely superb. And Nazani's also mentioning Rocky Mountain spotted fever for sure. So yeah, I think that the presence of the rash here is important to pay attention to. And within the viral category, it's often hard to distinguish clinically between Zika, chikungunya, and dengue. And in all comers, dengue is the most common. But in terms of of being a champion at causing a rash, Zika by far and away wins, followed by dengue, followed by chikungunya. So I think Zika here has to creep up in your differential diagnosis, especially if we learn that there is no visceral imprint of this disease, meaning that the labs are fine, the liver is fine, because Zika is the most superficial of these infections. It affects the eye and the skin, and unfortunately, in some cases, can go to the brain, which this patient is, of course, signaling to us with the neck stuff. but I think dengue is certainly not off the list. And then within the bacterial category, whenever you have fever and a diffuse rash like this, the most important bacterial infection to think about in all comers is toxic shock, but in this specific situation, to think about rickettsia. Salmonella can do it with the rot spots, usually on the belly, not so much on the extremities. So you probably should put that in there because it's common and can cause a rash. And I don't know of much of an overlap between malaria and rash. I'll have to read more about that. I don't think it's a common prominent descriptor, but I think the base rate in all comers would say that malaria should probably be considered no matter what you find. So I think the rash here is really, really interesting. You can study what happens to the patient after you measure their blood pressure, because if I forget what the name of the sign is, maybe you all can teach me in the chat what it's called, but you can essentially see fragile blood vessels after inflation of the cuff, which would point you into a vascular tropic infection, of which dengue is the most prevalent, but yellow fever can do it too, as can some other ones. So what would you do in this situation? I think you'd be a little bit worried about whether you need empirical therapy or not, meaning therapy before a clear diagnosis. I think that the real decision is, do you do a lumbar puncture in this patient or not? And I think if you are lucky enough that the labs show a very characteristic signature of a specific disease, you might be able to avoid it. And here's what I'm thinking about. If you get a patient who has leukopenia, an elevated hemoglobin, and low platelets, that is fairly characteristic of dengue because it causes leukopenia and thrombocytopenia. And then the vascular bleeding tendency can cause hemoconcentration. So if you get that pattern, you might say, hold on, this is too characteristic of dengue and the patient has low platelets, so let's avoid the lumbar puncture. But absent any obvious contraindication on labs with coagulopathy, or absent any strong indication of what the diagnosis is, I think that's something we'll have to think about hard in this patient. And many people in the chat, Rebecca and David, are reminding me that the blood pressure sign is called the tourniquet test. Thank you, guys. So Zach, I'm curious if you may have seen the patient after this, or may have seen the patient at this juncture. I don't know, but I'm really curious to sort of get what you were thinking at this juncture. What was crossing your mind at this point in the diagnostic exercise?
Yeah, so when I took care of this patient, I was actually on a consultant team. So we had the luxury of kind of a lot more clinical information than the admitting team did when they initially saw him. But yeah, you guys are kind of mentioning all the same things that we did. We were definitely concerned that it could be meningitis, just given how morbid that diagnosis is. And that's one of the things you kind of can't miss if someone's coming in with fever and headache. So he was started on empiric meningitis coverage. I think he got vancomycin and ceftriaxone when he came in, given some IV fluids, and had a pretty extensive lab workup, which we can talk about if you guys are ready.
Let's do it. Thank you.
Yeah, so I'll start with a CBC. His white blood cell count was 13.8, and it was neutrophilic predominant. His hemoglobin was 12 with a normal MCV. Platelets were a little bit low, like 133. Let's see, let me get his chemistries pulled up. Chemistry panel, he had let's see, sodium, potassium, chloride. His BMP was essentially normal. His albumin was 3.4. His bilirubin was total bilirubin was normal, and his AST was a little bit elevated at 123, and ALT was elevated at 74, and his alk phos was normal. He also had a CRP checked that was above the upper limit of detection at greater than 240, and had a ferritin checked that was 2000. And I have a lot of other lab data, so I'm happy to list it all off, or if you guys want to kind of ask for certain things and I can kind of give you those, we can kind of do it however you guys want.
Yeah, no, Zach, I think you've given us a lot to think about here. Folks, please share your thoughts in the chat and call out for things that you're looking for. I think that I think that the laboratory signature gives me a pause, because I think the only way that we could have moved to more specificity of the labs is sort of the opposite pattern of what we're seeing, where leukopenia or thrombocytopenia. And I think here labs give me a little bit of pause. The liver enzyme elevation is very much in line with many arthropod-borne infections. The thing that I don't know too much about is the ferritin in this context. Of course, when somebody has a fever and a high ferritin, the most important thing to think about from a diagnostic perspective is this a fingerprint of an early picture of HLH? However, ferritin is an acute phase reactant, and 2000 may be simply the non-specific effects of any infection. So, I think, what would I do in real life? I think I would sort of like, I would sort of tidy up the workup with an X-ray and a UA. I think for me now, given the non-specific lab findings, would probably proceed with an LP. But let me see if I can get your thoughts, and we'll go from there. Hans, what are you thinking?
I still have no picture. I'm just a little bit flabbergasted about the ferritin, why it is so high. And then the white blood cell count, neutrophil predominant, that just tempted me think about a bacterial infection, neck pain. So maybe the LP is an excellent idea.
I love it. I couldn't agree more. David, where's your head at?
Well, I think, yeah, you have to exclude meningitis here. I would not be reassured if an LP was not done here. So, well, I think there's maybe I would ask for a CT before, because not sure if any. I think it's not. I don't have this flavor, but any infection that could have also brain lesions such as toxoplasma, etc. We have to rule that out before the LP, and an HIV test would be also helpful. But yeah, definitely an LP.
I love it. I love the reinforcing of the LP, and then definitely thinking about an HIV. Sorry, I choked on this water. Rebecca, I'm not sure if you can replace her on mute, because I don't want to assume, since you have your video off, but I the point that you made about, hi, good morning or good afternoon. How are you?
I'm great. How are you? Thanks for having me.
Time no see. It's so nice to see you. How's your kiddo?
There's 2 now and they're good.
Congratulations.
Yeah.
How did you do that?
Yeah, my baby's turning 1 next week. Anyway, tell me what you're gonna say. We'll chat later.
I'm so curious about the point that you made. I think it deserves a lot of amplifying, about how you think of empiric therapy in a patient like this.
Yeah, I think, specifically if you're worried enough to be starting empiric coverage for meningitis, I kind of take it a bit as an all or nothing approach, meaning if I'm worried enough to say this guy could have bacterial meningitis or viral meningitis, I'm covering for all the organisms that he's at risk for, presuming that I'm going to get the LP pretty quickly. And so in a patient like this, who's a 27-year-old otherwise healthy guy, it's going to be vancomycin and then using acyclovir to cover HSV meningitis, which would be the only viral meningitis for which we actually have treatment, right? If this turns out to be West Nile or Eastern equine or any other viral meningitis, there's not going to be any specific treatment. And then, of course, if this was a patient who was a neonate, which I haven't taken care of in about 15 years, or anybody over 50, I would also add ampicillin to this coverage. But I don't necessarily see the need to kind of split hairs in this case and say, oh, I think this sounds maybe more bacterial, so I'm just going to do the vancomycin. I would probably say, again, in the 3, 4, 5 hours that you're waiting between the time he walks in the door, getting the LP, and then hopefully getting at least some preliminary results. And a lot of places now, not everywhere, but a lot of places have a pretty rapid turnaround meningoencephalitis panel, where you can find out very quickly whether the patient has any either bacteria or viral kind of pathogens in their CSF. I feel like the 1 or 2 doses of acyclovir is going to be a small price to pay for the coverage that you get from that.
I think that's so well said. It stands on its own. Thank you so much for saying it so well and so clearly. Ravi is bringing up a very interesting hypothesis. Ravi, are you able to share it out loud?
Sure. I'll put in the chat a tutorial that I did on mosquito bite reactions, and one of them was an exaggerated cutaneous response in patients that have hematological malignancies. I always wondered why somebody with CLL would have this hypersensitivity reaction. Then the other one was, you mentioned EBV, so linking EBV, I did find, I'll again put it in the chat, that hypersensitivity mosquito-borne or bite reactions could progress to systemic diseases. Like you mentioned HLH, this ferritin comes into play as well. So something connecting a few comments that were brought up before.
I love it. The master connector and conductor, Ravi. That's so, so cool. I remember reading that tutorial and I can't wait to read it again. Thank you. I think that the conversation around meningitis and empiric treatment and LP is very, very important. I'd say there's a lot of practice variability. So Zach, if that's not what the team pursued, I think that that's probably not too surprising, honestly. But I will add one other thing, which is when you're thinking about empiric therapy for meningitis is exactly what Rebecca just taught us. And then you have to think about empiric therapy from the lens of a fever and a returning traveler. And what that does for you, empiric therapy in that situation is usually ceftriaxone for leptospirosis or salmonella empirically, is doxycycline for rickettsial infections, and then thinking about empiric malaria treatment in somebody who's very, very ill, though you can usually verify the diagnosis of malaria fairly quickly. But so empiric stuff while you're waiting for tests that take a while to come back is usually ceftriaxone, think lepto and salmonella, and doxy for the rickettsial organism. So that's probably part of our calculus, taking care of this patient. All right, Zach, we can talk on forever. So please tell us more.
Hey, sorry about that. My internet just went out.
No worries at all. You all right?
Yes. Yeah.
Right.
No, I think my internet router just kind of cut out for a second.
No worries at all.
Yeah. So yeah, the patient did get vancomycin, ceftriaxone, and acyclovir. He did get a lumbar puncture that was normal, and the HSV PCR was negative. I think you'd mentioned wanting a UA and a chest X-ray, Robbie, that were both normal as well. Let me get his labs pulled back up. I had his EMR chart pulled up, but my EMR closed when my internet went out.
No worries at all. Take your time. I think the LP being normal is tremendously reassuring. However, it being done so quickly after his symptoms should give you some pause. I learned just yesterday that 15% of patients with histoplasmosis have a completely normal LP at index presentation. 1% of patients with bacterial meningitis have a normal LP if it's done very quickly. So one of the consequences of being such a great treatment team for this patient is that you might have done the LP. You should still do it, but you have to know its test characteristics early on. So there are many cases where the LP is falsely normal early on, and so you have to continue to hold that fact. Though in most cases, when the LP is normal, the conversation about meningitis is over, but it's not over every time. All right, Zach, tell us more.
Yeah, yeah, no, that's fine. My does not want to pull up right now, so I don't have all the labs in front of me, but kind of at this point, he had malaria thick and thin smear that was negative. Okay, it just pulled up. So we can kind of go through some of the other tests that we ordered. Malaria thick and thin smear that was negative. He had like a upper respiratory pathogen panel that was negative for a bunch of different upper respiratory viruses. He had CSF tested for kind of several different things. I think not sure who decided to send all these, but he had like crypto antigen sent that was negative, CMV that was sent, HSV 1 and 2 that were both sent and negative. He had a HIV screening that was negative and a negative viral load to rule out kind of acute HIV causing this. Also had negative hepatitis serologies, negative syphilis serologies, a negative monospot, and let's see what else we had for him. I think those were the big ones. Given the labs, I think the probability of it being dengue or anything like that was lower and lower. So we didn't send off any additional serologies like for that. What I will say is there was kind of a turn during the admission. During one overnight period, he kind of developed kind of acute pleuritic chest pain. And had an EKG that showed kind of diffuse ST elevation and PR depression in limb leads, and had a little bit of a troponin elevation in like the 2000 range. And so kind of developed acute pericarditis, myopericarditis while he was here in the hospital. And an echo at that time showed an EF that was 20 to 25% with no symptoms of heart failure. So that's kind of, when that happened, we were like, okay, we're kind of missing something here, and had to go a little bit back to the drawing board. So I'm curious to hear what you guys think of kind of that information, how you would integrate it to the case.
Absolutely incredible. Okay, this is a huge turning point, and I think now, I'll wait for thoughts to collect in the chat, but I'll say this: a fever plus myopericarditis should push you to think of infectious causes of myopericarditis. What are they? There are many. In terms of the viral categories, that's when there are so many, but the two important ones to think about right away are the ones that are increasingly more common, and they both start with C: Coxsackie virus or COVID. The bacterial causes are many. The most common worldwide is from diphtheria, but Listeria can do it, as can Campylobacter. In terms of the parasitic causes, they're usually associated with eosinophilia. This is when you have toxocariasis or trichinella or toxoplasmosis or even trypanosomiasis or acute Chagas disease. However, this case is most suggestive so far of COVID. Why? MISA, or multi-inflammatory system disease A in adults, is a COVID-related complication that presents with a combination of cardiac skin manifestations and a set of fairly characteristic laboratory abnormalities, including a high ferritin, and more importantly, as is uncharacteristic of most viral infections, presents with a neutrophilic leukocytosis. So for me, I think this doesn't confirm that hypothesis, but the pattern here is emerging decently to suggest that, which would push me to, of course, get a COVID swab, but also COVID antibodies, because up to a third of patients have cleared their virus and only show up recent COVID infection on their serology. It's a great reminder of a fever in a returning traveler is a less important frame when you're dealing with a pandemic where the infection is everywhere. But that's the change that this does for me. The one exception to this whole conversation is still thinking about rickettsial diseases, which carry a tremendous rate of myopericarditis only in critically ill people. So the fact that his myocarditis is out of proportion to everything else, the fact that he's not in the ICU on death's door, makes a rickettsial infection untreated less likely. So there's a lot to do here, but for the sake of simplicity and rapid thinking, this case, the development of myopericarditis in the context of the leukocytosis and ferritin would push me to really start to worry that this young man is developing MISA as a post-COVID complication. All right,
Yeah.
tell us, everybody.
Yeah, no, I love the discussion. That's kind of exactly what we were thinking after we'd excluded a lot of these kind of travel-associated infections that we were initially really worried about. So he did get a COVID PCR that was negative, but his COVID IgG antibody was positive. and he was started on empiric steroid treatments, and his symptoms got better very quickly. Cardiology was consulted just as part of, because of the myopericarditis. He did get a cardiac MRI that confirmed there was myocardial inflammation. And he was started on some goal-directed medical therapy for the cardiomyopathy he developed. And he was discharged a couple of days later after starting steroids because his symptoms improved so rapidly. Had followed up with cardiology, repeat echo showed his cardiomyopathy had resolved. And he was weaned off all of the GDMT that he was started on, and is currently, from what I can gather, back to his previous baseline with no significant deficits related to this episode.
Wow, that is incredible. What a plot twist. Here we are, dengue and rickettsia and whatnot, and it's COVID all over again.
Yeah.
Zach, what was it like to be involved in this patient's care? What did you learn?
Yeah, I think learned that problem representation is super important, because the initial frame for this patient was he's a fever in a returning traveler. And we're like, oh, he has to have malaria, dengue, chikungunya, one of these things, since the timing seemed to fit with that. But that's not the appropriate frame for this patient. He was a returning traveler who presented with fever. But if we hadn't asked about this prior COVID infection, we may not have even considered MISA as a possibility. So I think that was a big learning point for me, was I guess, one, the differential for fever in a returning traveler, which is an important thing to have, but then also just the importance of making sure you have the appropriate frame for the problem, so you know what else to look for, and hopefully find the right diagnosis and get them to the right treatment.
That's so well said. It's not somebody, the frame isn't returning traveler with a fever. I'll take the yogurt out of my hands to illustrate it visually. Like, this case is not a returning traveler who happens to have a fever. It's a fever in a person who happens to be a returning traveler. And how you set that up in your problem representation, Zach, I think is absolutely superb. And at the end of the day, I think that if you didn't have that frame, what would rescue you is a helpful approach to myopericarditis. And I think a lot of these, in the middle of sharing all that, I'm just amazed that a tool over 100 years old, the EKG, was probably what really cracked this case, at least for me it was. But how having a reflexive approach to, oh, my patient has fever and myopericarditis, what could it be? And I think in the modern era, you really, really have to think MISA for COVID. I mean, that should be a reflex, unfortunately. So yeah, thank you for sharing this case, Zach. It was such a cool journey. I think you had us hooked the whole time. Until you showed the EKG, I had absolutely no idea where this was going. I really did, which is a really cool feeling, and one that I think means we're learning a lot. Thank you for your first ever presentation. I think you should represent this like 10 times on your CV for the amount of education.
Thanks.
I really, really appreciate that. We hope to see you on VMR as often as a resident schedule will ever really allow. All right, Sarah, take us home, please.
All righty. Thank you so much for this case, Zach. There was so much rich learning, so I tried to distill some teaching points. I hope they're reasonable for this case. But we started with an approach to fever in a previous healthy patient. And so we start big and go small. So starting big with base rates, viral is more common than the viral is going to be more common than bacterial infections. But in this patient, we have a localizing sign, which is fever and neck pain, which is worrisome for a CNS process. When we think about what we can do to narrow down our differential, we need to think about the 4 W's of infection, which is who, when, what, and where. And in this case, the patient's who and their what, where, the fact that they were a young, previously healthy person. And also we were initially thinking because they were a returning traveler, we decided to reframe this case as a fever in a returning traveler. And then the branch point in the differential here is going to be the incubation period as well as the geographic area. So for the incubation period, if there's a short incubation period, we can rule out things like TB leishmaniasis, and fungal infections. And for short incubation periods, we can often think about dengue, Salmonella typhi, and then malaria. And then in the chat, they were shared this resource that has a lot of information about different infections based on geographic area and incubation period, which you can reference later. And then something else that occurred in the case on the physical exam that can narrow down our differential includes the macular rash. And so some differentiating features among diseases for this include that Zika is more common with a macular rash than dengue and chikungunya because Zika affects more superficial structures. The differential diagnosis also can include malaria, rickettsial rashes, mosquito bites, and also viral exanthems. And then one of the differentiating physical exam features can be the tourniquet test, which is testing capillary fragility under a blood pressure cuff. And then a positive test for this can indicate dengue fever. And then when we got to the lab values, we wanted to see, do we need an LP or do we not need an LP? And this depends on if you can find identifying clinical features in the labs that can point to specific infections. So one example is that leukopenia, elevated hemoglobin, and low platelets can indicate dengue fever. But even if you get an LP and it's negative, you should consider false negatives if the LP is completed soon after symptom onset. And then while doing an LP, we need to think about empiric antibiotic treatment. So for meningitis, empiric therapy, that'll be vancomycin, ceftriaxone, and acyclovir. And for empiric treatment in a returning traveler, we need to consider ceftriaxone, doxycycline, and malarial treatments. Another one of the differentiating features in the labs include fever and high ferritin. For the differential, this includes acute phase reactant, elevations of ferritin, HLH, and then COVID or MIS-A. And then when we got to the EKG, this is the major branch point in this case. The differential includes viral causes. And in this arrow, we should really be thinking about COVID and Coxsackie virus, bacterial infections, and then parasitic infections like Chagas, which present with eosinophilia. And then finally, we learned that COVID and MIS-A can present in numerous ways, including myopericarditis. And these presentations can present slightly differently than we would expect with a neutrophilic leukocytosis and an elevated ferritin. So these are all my teaching points for today. Thank you so much for this case and this learning.
Yeah, that was incredible. How did it feel?
I'm always nervous when I do teaching points because there's just so much to learn and I want to make sure that it's like well organized for everyone. So yeah, I'm still practicing and improving.
We're all practicing for life, honestly. And I had the benefit of knowing how you did this a long, long time ago. And it's so cool to see you take this complex case and represent it visually with so much clarity, and also how you narrated. I think what's really cool to see is you've developed a robust skill set to know what to emphasize and what not to, including in your delivery too. That was awesome. Thank you so much for doing all that. I can't believe we nerded out this much in this hour. Thank you, Zach, for making it happen. Thank you, Sarah, for recapping it. Thank you, Deborah, for getting it all on the screen and much more, and checking in on me as I aspirated on my own water hydration. I appreciate that, Deborah. All right.
Ravi,
Yes.
can you tell everyone what we'll have tomorrow?
Oh my gosh, I completely forgot. How bad. Can you tell everybody?
Yeah, so tomorrow we are going to have a special global VMR with our friends. So we are super excited, and it's the country that Ravi lived for many years. So I think we'll be really excited for him too. What do you think?
I'm so excited. We have Danya and her friends from Pakistan joining us tomorrow. It should be a really fun case and conversation with people who are absolutely incredible. I can't wait to do it. It's at 7 a.m. Pacific tomorrow, so 2 hours before today started. I'm really, really excited for it. So if you can make it, it'll be awesome. If not, I hope to see you the time after that. Thanks for the reminder, Deborah. Bye.